morning, everyone, and I really apologize that I haven't been there in person with all of you. And my topic for today is immunotherapy in gynecological cancers. Where do we stand? So while immunotherapy is rapidly altering the treatment landscape in several solid tumors, the efficiency in advanced gynec malignancies has so far been limited. And recent studies have established the role of IO in endometrial and cervical cancers. We now have phase 3 data available. It is less established in ovarian cancer, and we perhaps need better patient selection. So let's look at the current data and see where gynec malignancies start in the milieu of immunotherapy. We first start with endometrial cancer, and this is very interesting data from PORTEC-3. And we know that we have 4 different subtypes which tell us the prognosis and how they respond. So 28% of them are usually MMR deficient tumors. And if you can see, there was not much benefit from the addition of platinum to radiation in this group. And perhaps adjuvant immuno would be a better strategy in these cases. So if you look at the TCGA data where they looked at over 11,000 tumor normal samples, MSI was identified in 3.8%, and the highest rate of MSI was observed in endometrial cancer, and almost 31% of endometrial cancers harbored MSI-H phenotype. These are the single agent efficacy studies in biomarker selected patients. So avelumab, durvalumab, dostarlimab, and pembro have all been tried in these small phase 2 studies. And you can see that the overall response rates have varied from 27 to 57%. Let's look at the Keynote 158 a little more in detail. And this was the non-colorectal study. If we look at the endometrial cancer cohort, you can see that the overall response rate on the upper left side was about 48% for all. And this varied and was much more in those who had received less lines of prior therapy, 53%, versus those who'd received it later on, suggesting that if you're using immunotherapy, it's better to use it up front. The median duration of response and overall survival were not reached. The treatment-related AEs grade 3 to 4 were 12% as expected, and the progression-free survival in this group was 13.1 months, which is pretty good for this pretreated cohort. Let's turn our attention to the GARNET study, which used a different PD-1 inhibitor, dostarlimab. And this is the endometrial cancer cohort. Here again, you can see overall response rate of 47%, again higher, 50% in one prior line of treatment, compared to 35% with more than or equal to 2 prior lines. If you look at the bottom right cartoon, you can see that at 12 months, 46% of patients were alive, and at 24 months, 40%, which is pretty good. And in those where the duration of response was not reached, the probability of remaining in response at 2 years was a whopping 84%, so encouraging data. This has led to the design, naturally, of 2 phase 3 trials, studying pembro and dostar in the first-line setting, where they will compare it to paclitaxel carboplatin. What about IO in MMR proficient endometrial cancers? Because we know that almost 60 to 70% will be proficient MMR. And is there a strategy for these patients? Certainly. So Dr. Vicky Marker and a group from Memorial Sloan Kettering looked at this population where you could leverage the activity of immunotherapy by adding anti-VEGF. So patients were randomized to lenvatinib pembro versus treatments of physician's choice of doxo or paclitaxel. This was a predominantly MMR proficient population. It met its primary endpoint of PFS benefit of 7.2 versus 3.8 months, and overall survival benefit of 18.3 versus 11.4 months. And there was a 5-month overall survival benefit seen in the proficient MMR comers as well. So this is a strategy we can use in the clinic. Let's turn our attention to cervical cancer. What's really the rationale for immunotherapy? We know it's a virally driven cancer. Almost all cases have HPV infection. We know that PD-L1 is overexpressed in squamous cell and adenocarcinoma. And we also know that cervical cancers have a high tumor mutational burden rate. This is early trials, phase 1, phase 2 data. Here, it was regardless of PD-L1 status, where pembrolizumab, nivolumab, and balstilimab were tried. And you can see that the response rates were more in the CPS positive population or the PD-L1 positive population. Based on this early data, FDA approved in June 2018 pembrolizumab for patients of recurrent or metastatic cervical cancer who progressed on or after platinum-based therapy. And following the full approval, which I will show you in the next slide, of pembrolizumab for metastatic recurrent cervical cancer in October last year, Agenus withdrew its application for the use of balstilimab. So this is the Keynote 826, which is a phase 3 randomized double-blind placebo trial of pembro plus chemo plus or minus bev versus placebo with paclitaxel cisplatin plus or minus bev. And if you look at the dual primary endpoints, which were PFS and OS, you can see impressive hazard ratios of 0.62 and 0.64 respectively. And at 12 months, 45% of patients were progression-free compared to 34% without pembro. And if you look at the 24-month survival rate, 12% more patients were alive at 2 years with pembrolizumab compared to without. So there was another study with another PD-1 inhibitor called cemiplimab, and this was compared to chemotherapy. And in the squamous cell group, the overall survival was better for cemiplimab in overall population, 11.7 versus 8.5 months. In adenosquamous group, which we know is a real poor prognostic group, this benefit of OS was also seen, 13.5 versus 8 months, and this benefit was seen irrespective of PD-L1 status. In summary, pembro has been approved with chemo as first line in metastatic cervical cancer for patients with a CPS more than 1. Cemiplimab is approved in some countries, especially Europe, as second-line treatment after failure to platinum. I didn't have the time, but there is a combination data which is now being studied very avidly of PD-L1 and CTLA-4 inhibitors, as well as anti-TIGIT and PD-1 inhibitors. Adoptive cell transfer of TILs have been encouraging. They've been granted breakthrough status, and trials in locally advanced cervical cancer are also studying the addition of immunotherapy to chemoradiation. What about ovarian cancer? So this has been left behind, and immunotherapy has been a little disappointing. Single agent has shown very low activity. We've combined it with BEV, no activity, even in relapse. When patients are selected out for CD8 positivity and PD-L1 positivity, a little activity is seen. But there are innovative strategies which include TIL, dendritic cell, vaccinations, and cocktail of tumor-associated antigens. So in conclusion, immunotherapy for ovarian cancer has been challenging due to a low tumor mutational burden, a very highly immune suppressive environment, and after the disappointing results of immune checkpoint inhibitors, we need to perhaps understand the landscape better to guide the ongoing attempts towards IO in ovarian cancer. With that, I will end my talk. Thank you for your attention.